Good afternoon. It is my pleasure to welcome you to the mini plenary on pelvic inflammatory disease. I'm Ellen Kirsch from the STD laboratory branch at CDC, and I will be monitoring the session. We will have 3 speakers today, each with a 15-minute presentation. I would like to warmly thank them for accepting this challenge, for working diligently on their talks, in dealing with any and all technical challenges and dry runs that we had them participate in. So thank you for doing that. We will hold questions until the end if there's time. If you do have a question, please use the Q&A feature to type them in on the top right of your screen. You can see that tab. There are credits available. If participants are interested, please go to the conference website to see how you can earn them. Please also be aware that we have changed the order of presentations from what is printed in your program. So we will first go to Kristen Kreisel, then Susan Kuuvin, and then Sharon Hillier. So with that, I would now like to introduce our first speaker. It's my colleague, Dr. Kristen Kreisel. Kristen received her PhD in molecular epidemiology from the University of Maryland in Baltimore. She's currently a chlamydia surveillance epidemiologist in my sister branch, the surveillance branch here at CDC in the Division of STD Prevention, where she does wonderful work. And she will speak to us and give a presentation she gave at a recent CDC consult on PID, and it is titled The Epidemiology of PID in the US. Kristen, welcome.
Thank you. Welcome, everyone. Good afternoon or morning, depending on where you are. So I'm going to just jump right in. So as the chlamydia surveillance epidemiologist at CDC, a question that I often get is, what's going on with PID? And the short answer to that question is it depends on where you look, outside of the pelvic area, of course. And the long answer is that there are several data sources that can monitor PID, each with different characteristics, such as different sampling designs, study populations, and methods. And so I posed the question about a year or so ago about what all of these data sources say about PID, whether the findings are consistent between the data sources, and if they're not consistent, why they're not consistent. So last year, I formed an analytic team, each person having access to 1 or more of 8 data sources. Included in our analyses were 2 nationally representative population-based surveys, the National Health and Nutrition Examination Survey, or NHANES, and the National Survey of Family Growth, or NSFG. There were 4 nationally representative data sources covering specific populations, the first being the Healthcare Utilization Project, or HCUP, the National Hospital Ambulatory Medical Care Survey, or HAMCS, the National Ambulatory Medical Care Survey, or NAMCS, and the National Disease Therapeutic Index, or NDTI. And there were 2 non-nationally representative sources with data on specific populations, the first being MarketScan, and the second, the STD Surveillance Network, or SUN. So today, I'm going to walk everyone through a short description and key findings from each, and I'm going to pull all of that information together to provide a complete picture of PID in the United States. So let's start with NHANES. NHANES is a complex survey that is nationally representative of the non-institutionalized US civilian population. Participants undergo an exam and an interview, and females are asked questions about whether they have ever been treated for PID. We evaluated the prevalence of a self-reported lifetime episode of PID in sexually experienced females aged 18 to 44. So in the 2013 to 16 NHANES cycles, the prevalence of self-reported lifetime PID in this population was 4.1%. And if you extrapolate to the population of all women aged 15 to 44, there were an estimated 2.4 million US women having been diagnosed with PID in their lifetime. Stratified by age, prevalence increased with increasing age. Stratified by age and race ethnicity, prevalence was highest in Black non-Hispanic females in all age groups versus all other races. Stratified by behavioral risk factors, prevalence was higher in women with a sexual debut under 16 years old versus those above 16. sorry, I lost my place. Higher among those with a prior STI and those with more lifetime vaginal sex partners. Stratified by race and risk factors, the prevalence of lifetime PID among women with a sexual debut under 16 years was similar in Blacks versus all other races, but was more than doubled in Blacks compared to all other races with a sexual debut of 16 and above. Prevalence was higher in Black women versus all other races, regardless of having had a prior STI, and also regardless of the number of lifetime partners they had. So in NHANES, we found that 2.4 million US women have been diagnosed with PID in their lifetime. We confirmed the traditional sexual risk factors, and Black non-Hispanic females are disproportionately impacted compared to all other races. Next, we evaluated trends in lifetime PID and NSFG. NSFG is also a complex survey where PID is based on self-report, and we similarly evaluated prevalence in sexually experienced females age 18 to 44. In NSFG, the prevalence of lifetime PID decreased from 8.6% in 1995 to 3.4% in 2013 to 15, and slightly increased to 3.6% in 2015 to 17. Extrapolated to the population, an estimated 2.1 million US women self-report having been diagnosed with PID in their lifetime, which I think is pretty darn close to NHANES. Stratified by age, prevalence was highest in women aged 35 to 44, and trends decreased in all age groups. However, we see this slight increase in 2015 to 17, with the largest increase among 15 to 24-year-olds. Stratified by race ethnicity, prevalence was highest among Black non-Hispanic women, but there were declines in all groups. Black non-Hispanic women, however, were the only group that saw an increase in 2015 to 17, increasing from 3.8% to 6.3%. So in NSFG, we found declines in the prevalence of lifetime PID from 1995 through 2017. However, there was a slight increase in 2015 to 17, with largest increases among 15 to 24-year-olds and Black non-Hispanics. So now I'll discuss nationally representative data on specific populations, the first being HCUP. HCUP includes 3 state-specific and 4 nationwide databases. One of the national databases is the Nationwide Emergency Department Sample, or NEDS, which is the largest all-payer publicly available database of ED visits in the United States. We identified PID ED visits using ICD codes in females aged 15 to 44. In HCUP, we found declines in the proportion of PID ED visits during 2006 through 16, and we found a similar increase compared to NSFG in 2016. Of note, the transition to ICD-10 started on October 1st of 2015. So to evaluate for any impact this transition may have had on trends, we evaluated data for the first 3 quarters of 2015 and compared to quarter 4, and we didn't find any discernible differences. Stratified by age, the proportion of PID ED visits was highest in 15 to 24-year-olds, and like NSFG, there were also declines in all age groups, with a small increase in 2016 in all age groups. Stratified by region, we found that the proportion of PID ED visits was highest in the South, with declining trends in all regions, and again, with that small increase in 2016. Stratified by age and region, there were declines nearly across the board, with 15 to 24-year-olds in the South with the largest decreases. So in HCUP, there were declines in the proportion of PID ED visits in nearly all age groups and US regions, with 15 to 24-year-olds in the South with the largest declines. And the same increase that we observed in NSFG, we also observed in HCUP in 2016. Okay, so on to 2 nationally representative ambulatory care surveys. The first is HAMCES, which is a national sample of visits to EDs, outpatient departments, and ambulatory surgery centers, and our analyses focused only on ED visits. Second is NAMCES, which is a national sample of visits to non-federal office-based physicians. we identified PID visits in both using ICD codes in females aged 15 to 44. So in HAMCs, we found declines in the number of PID-ED visits during 2010 through 16, and the same increase starting in 2016 that we observed in both NSFG and HCUP. Using NAMC's data, there were declines in the number of PID physician office visits, but where other data sources have seen an increase in 2016, NAMC's showed a decrease in the number of PID physician office visits. So in HAMCs and NAMCs, the number of PID, ED, and physician office visits declined during 2010 through 16. And although we saw the same increase in 2016 for ED visits due to PID, there was a corresponding decrease in physician office visits during that same time frame. Okay, so our last nationally representative data source is NDTI. NDTI data are reported by participating physicians and are projected to estimate all patient contacts for all workdays for all private physicians in the United States. We used ICD codes to identify visits among females aged 15 to 44 presenting for their initial PID office visit. And in NDTI, the number of initial PID office visits decreased from 146,000 in 2007 to 90,000 in 2016. We found an increase in PID office visits starting in 2015, which contrasts our NAMC's findings. However, after looking at the trend over time, it really could just be part of normal trend fluctuation. So in NDTI, the number of initial PID office visits declined during 2007 through 16. However, there was an increase in visits starting in 2015. So next we'll move on to Market Scan, which is a large convenience sample of commercially insured persons in the United States. Uh-oh, I lost my slides. Can you also see them? Here we go. Okay. Okay, so Market Scan data contain healthcare claims for inpatient and outpatient services, and we used ICD codes to identify PID claims among females aged 15 to 44. And in Market Scan, the overall rate of PID in commercially insured women was statistically stable during 2009 through 17. And there was the same increase in 2016, but we had an additional year of data in Market Scan, and we saw a subsequent decrease in 2017. But again, after looking at this trend, it could just be part of normal fluctuation, and it's going to require more years of data to determine if it continues. Stratified by age, the rate was highest in 25 to 34-year-olds, with declines among both 25 to 34 and 15 to 24-year-olds. Stratified by region, rates were highest in the South, with declines in both the South and Midwest. Stratified by care setting, the proportion of PID claims increased in the outpatient setting during 2009 through 17. And the proportion of outpatient visits was consistently highest among 35 to 44-year-olds. Just lost my slides again. Ellen, can you see them? Okay, came back up again.
They're back, yeah.
Okay. Okay, so in Market Scan, women aged 25 to 34 and those living in the South had the highest rates of PID. Rates decreased in women aged 15 to 24 and 25 to 34, and in the South and Midwest. The proportion of PID outpatient visits increased, with older women being more likely to seek care in outpatient settings. Okay, so our last data source is SUN. SUN is a sentinel surveillance program performed in specialty STD clinics where data are collected, including STD-related diagnoses and sequelae. We evaluated females aged 15 to 44 diagnosed with PID at STD clinics in SUN. The blue bars in this figure represent the total number of women aged 15 to 44 presenting to STD clinics, and the green bars, which are on the secondary axis, represent the proportion of those women diagnosed with PID. In SUN from 2010 to 2017, the the number of female STD clinic attendees decreased by about half, but the proportion of those diagnosed with PID stayed low and stable at around 1%. Stratified by age group, PID appears to be increasing in older age groups. This is kind of hard to interpret because we also have data that we are not showing here that shows fewer younger women are presenting to the Sun STD clinics in the first place. The racial profiles of those diagnosed with PID has stayed relatively stable over time, with Black non-Hispanic women accounting for the majority of PID cases each year. Among women with PID tested for chlamydia and gonorrhea, positivity for chlamydia ranged from 10 to 17%, and for gonorrhea from 3 to 8%. So in Sun, we found that less women are attending STD clinics, but among those who do, the proportion diagnosed with PID has stayed low and stable. Also, among PID cases tested for chlamydia and gonorrhea, positivity ranged from 3 to 17%. Okay, so let's all take a deep breath. That was a lot of data. So here is where I am going to try to pull all of it together to provide the larger picture of PID in the United States. The first, we know that PID impacts over an estimated 2 million US women in their lifetime. Second, data suggest overall declines in PID over time and the potential for an increase starting around 2016. However, we need additional years of data to verify this. There were differences by age group, race, ethnicity, and region, with the highest burden in Black non-Hispanic women and those living in the South. There was some discordancy on the age group with the highest burden, but that was primarily due to how PID was measured in each data source. So for instance, in NSFG, 35 to 44-year-olds had the highest burden, but in HCUP, it was 15 to 24-year-olds. NSFG, however, measures lifetime PID prevalence, whereas HCUP measures incident PID cases. And lastly, given each data source has different methods, different populations, and different case definitions, creating a cohesive national picture of PID is a really challenging undertaking. These analyses did have some limitations. So first, all analyses were based only on symptomatic cases, which likely represent only the tip of the metaphorical PID iceberg. There are also inherent limitations to each data source, including small sample sizes, self-reported outcomes, and the use of ICD codes to identify cases. I think knowing these limitations is step one. What needs to happen next is identifying ways to address them. So I wanted to end with one suggestion for future research, and that is a validation of the ICD-10 PID codes, similar to the ICD-9 validation study that was published in 2011, as well as a full assessment of the impact of the transition to ICD-10s on PID trends over time. What we ultimately know about PID is really only as good as the data we have available to us, and understanding how to interpret PID data based on their inherent limitations is key to a true understanding of the burden of PID in the United States. And that is where I will leave it.
Thank you, Kristen. That was wonderful. We appreciate it. We will now move to our second talk. And again, if you have questions, you're welcome to type them into the Q&A section here, and we will get to them at the end. And with that, I would like to now introduce Dr. Susan Kuuven. She's a professor for OBGYN and Medicine and Health Services, Policy and Practice at Brown University in Providence, Rhode Island. She's also the director for the Providence Boston Center for AIDS Research and the director of the Brown Global Health Initiative. Susan received her MD from the University.
Hi, this is Dr. Kuuven from Brown University. And I'm going to talk about the screening for chlamydia impact the incidence of PID. My disclosures have been said. We will talk about the epidemiology of chlamydia infection in women, the sequelae of untreated chlamydia infections, recommendations for screening of chlamydia infections in women, the current screening modalities that we have, and evidence or lack of evidence that screening for chlamydia impact the incidence of PID. You all know this. I think everybody knows that the burden of chlamydia is more in women than in men all over the world. This data from the WHO does not include North America. And you also know that the incidence of PID is very hard to really configure properly, but there are about 127 million new cases all over the world each year. In the United States, per 100,000 women, you can see that there are states that have a heavier burden of chlamydia compared to the other states. It's also known that in the United States, per 100,000 women make up most of the diagnosis of reported cases of chlamydia. And it's all over, mainly in the South, but there's a cluster of all the states as of reported by 2018. By age group, this is no surprise to any of us. Chlamydia rates are mostly in the younger women, 24 and less in age. There's also the same pattern in men, but much of the burden of chlamydia is in women. This is another slide that just tells you again that the 20 to 24 years old from the 15 to 19-year-old groups in women make up most of the reported rates of chlamydia in the United States. Like PID, African Americans share the bigger burden of chlamydia infections in the United States, followed by other minority groups, and white women are less reported to have chlamydia rates. So what are the current recommendations for chlamydia testing? The USPSTF recommends screening for chlamydia in sexually active females aged 24 years or younger, and in older women who are at risk for infection. And they have a B recommendation for this. The CDC's recommendation is annual screening of all sexually active women aged less than 25 years of age is recommended, as is screening for older women at increased risk of infection. Example, women more than 25 years of age who have a new sexual partner, more than one sexual partner, a sex partner with a concurrent partners, sex partner who have sexually transmitted infections, and women with bacterial vaginosis or HPV infection. The Canadian STD guidelines recommend screening for chlamydia in asymptomatically sexually active people under 25 years and any other people with risk factors for other STIs and blood-borne infections. We all know that chlamydia is one of the most commonly reported sexually transmitted infection. It is 10 times more prevalent than gonorrhea in women aged 18 to 26 years of age. The incidence is difficult to estimate because most infections are asymptomatic and not diagnosed. Asymptomatic infections may lead to pelvic inflammatory disease and its associated complications such as ectopic pregnancy, infertility, chronic pelvic pain, and in pregnant women, neonatal chlamydia pneumonia or ophthalmia, and it may also facilitate HIV transmission. How about screening tests? Diagnosis by using nucleic acid amplification tests or NAT are highly sensitive and specific, and it's FDA cleared for urogenital sites such as samples from the urine, the endocervix, and the vaginal canal. As to screening intervals, there is an absence of quality studies on screening intervals. A reasonable approach is to screen patients whose sexual history or have new or persistent risk factors since the last negative result for a chlamydia testing. Let's look at the evidence whether screening for chlamydia can decrease pelvic inflammatory disease. Let's look at randomized controlled studies. This is a cluster randomized trial where they did cluster randomized controlled trial in rural towns in women ages and men ages 16 to 29 years. They had 26 clusters of 63 clinics, over 93,000 young adults receiving chlamydia testing intervention, and also 26 clusters, 67 clinics of over 86,000 young adults continued with the standard of care. The mean duration of this study was 3.1 years. And the primary outcome for this study is chlamydia prevalence before randomization and at the end of trial. This was done in Australia. The key findings showed that chlamydia prevalence decreased from 5% to 3.4% in the intervention clusters, from 4.6% to 3.4% in the control clusters. The absolute difference in treatment effect was small, and the adjusted odds ratios for difference between the groups was also small. However, the incidence of PID, according to hospital diagnosis, was 40% lower in the intervention than in the control group. This is just showing you the full data that it's only in the hospitalized group that they did show a statistically significant decrease in PID between the intervention and the control group. The other study shows the effectiveness of yearly register-based screening for chlamydia in the Netherlands. This was a controlled trial with a randomized step wedge implementation. There were 3 regions in the Netherlands that were included: Amsterdam, Rotterdam, and South Limburg. It included 17,304 women and men aged 16 to 29, and they offered yearly chlamydia screening tests by self-collection in the intervention group. The primary outcome was the percent of chlamydia test positivity, the percent of uptake, the estimate chlamydia prevalence, and a secondary outcome was the incidence of self-reported pelvic inflammatory disease. There are big limitations for this study because only 16.1% participated in the study in the first invitation, decreased to 10.8% in the second invitation, and decreased again by 9.5 to 9.5% in the invitation. There's 13% participation in the control group, which received the standard usual care. Chlamydia positivity was the same in the intervention and control block at about 4.3%. But among women who participated 3 times, which only consisted of 2.8%, chlamydia positivity fell from 5.9% to 2.9%. So there was no statistical evidence of an impact of chlamydia positivity rates after 3 years in this particular study. This is a Cochrane report that looked at previous studies, randomized controlled studies, and their effect on the incidence of pelvic inflammatory disease. As you can see, many of the studies did show a decrease in PID, but not all of them were statistically significant. All of them had limitations, and some of them, particularly the POPI trial, will tell you that there was not much evidence of a decrease in PID except for a select population. And in the Anderson study that did 9 years of follow-up, they showed no decrease in PID. Neither did they show any decrease in infertility as well as ectopic pregnancy. This is a study looking at the Manitoba retrospective study, the Denmark chlamydia study, comparing it to the POPI trial, which was done in the United Kingdom, which is a randomized controlled trial. Now, if you look at this, all of them show a decrease in pelvic inflammatory disease, but very small numbers in Denmark to start with. If you look at the POPI trial, which was done in high schools in the United Kingdom, there was a relative decreased risk among those that had deferred screening for chlamydia compared to those that were screened in real time. But there are limitations for this study. This study was underpowered, but it did show that among the women who had chlamydia positivity, there was a decrease in the incidence of pelvic inflammatory disease between the deferred screening and those that were screened. And this was a sizable effect, but it is only a limited portion of the population that was studied. The reason that I'm showing all of this to you is because even with randomized controlled trials, a lot of them had limitations, and the studies would show that there's evidence of a decrease in pelvic inflammatory disease by screening massively for chlamydia, particularly those that are asymptomatic. But none of the randomized controlled studies had no limitations at all, particularly those that lack power. I wanted to create a slide that would show them all side by side. But because of the differences in the design of the study, the endpoints, the diagnosis of chlamydia, the diagnosis of PID, the power of the study, it was not very fair to do a slide like they were being able to be compared equally and fairly. So I am sorry that I am presenting them to you study by study. In terms of randomized controlled studies, there are a lot of studies, from ecological studies to retrospective studies to other different designs. But you all know the limitations of randomized controlled studies. I can't do justice to all of these publications, so I chose representative studies that will show you different designs, different study groups, and different ways of approaching the problem. One of these studies that I'm going to talk about is a study presented by Den Hager in Clinical Infectious Diseases in 2019, showing chlamydia and the risk of pelvic inflammatory disease, ectopic pregnancy, and female infertility. And this was a retrospective cohort study among primary care patients. So the limitation is that it only represents primary care patients. But in the study, if you look at the positive chlamydia, they did show that the risk is higher in those that are chlamydia positive in terms of pelvic inflammatory disease, in terms of ectopic pregnancy, and in terms of fertility. Mind you, this is not a randomized controlled trial. The next study also shows the relationship between chlamydia infection and PID, ectopic pregnancy, tubal factor infertility, in a Dutch cohort of women previously tested for chlamydia in a chlamydia screening trial. This was published in STD in 2019. And in contrast to the previous study, they only saw a difference in terms of pelvic inflammatory disease between chlamydia positive and chlamydia negative in terms of PID, no difference in ectopic pregnancy, and also a difference in tubal factor infertility. Another non-randomized controlled study showed the association between enhanced screening for chlamydia and Neisseria gonorrhea and reductions in the sequelae among women. This is not a causal study, it's just an association study. As we increase the number of women that are being screened for chlamydia, there is a trend also of decrease in hospitalizations for PID, a decrease in hospitalizations for ectopic pregnancy, and emergency diagnosis of chlamydia and gonorrhea. There is no correlation or causal relationship. This is just to tell you that in temporal sense, the more screening you do with chlamydia and gonorrhea, there is also a trend of decrease in hospitalized PID, ectopic pregnancy, and that of the diagnosis of chlamydia and gonorrhea in emergency departments. I had only 15 minutes to show you everything, so I'm sorry to say that the controversy remains. There is evidence that massive screening for chlamydia, particularly asymptomatic chlamydia in the appropriate age group in women, decreases pelvic inflammatory disease. The controversy, I believe, is in the net benefit and the net effect, because not all PID are caused by chlamydia. So screening for chlamydia, I believe, has a moderate net benefit in females aged less than 24 years of age and older women at increased risk for infection. However, even up to this day, there's a paucity in the number of high-quality, randomized controlled studies to assess if the screening for chlamydia really decreases the incidence of PID. There are major limitations in all the studies that I presented, including the randomized controlled trial studies. They looked at different populations. The assessment for chlamydia incidence or prevalence is uncertain because they all use different parameters. There is selection and detection bias in some of the studies. There's no data on reinfection rates, which will affect also pelvic inflammatory disease incidence. They have different interventions. There are differences in chlamydia diagnostic testing, particularly the earlier randomized controlled trials to the more recent randomized controlled trials that using NAT. There are differences in PID diagnosis, either by ICD codes, by self-report, and also by clinical symptoms only. There are differences in the treatment interventions. There were differences in access to care. There was difficulty in enrolling the number of women, particularly those that use questionnaires and reminders and self-collection kits. We also have to remember that it's not only treating chlamydia in the females, but in testing their partners and treating their partners. We also, many of the studies, aside from Anderson that went on to 9 years, also had a short follow-up from 12 to 3 years. And the long-term effects of untreated chlamydia might be different from the 12-month follow-ups that have been done in these studies. I wish I could give you a clear answer and say that we have resolved this controversy, but I can't. I can tell you again that massive screening of the appropriate age women for chlamydia, there is evidence that it decreases PID, but the public net health effects is still in question. Thank you very much.
Thank you, Susan. That was excellent. It is my pleasure to now introduce our third and final speaker, Dr. Sharon Hillier. Sharon is currently the Richard Sweet Professor of Reproductive Infectious Diseases and Vice Chair of Faculty Affairs at the University of Pittsburgh School of Medicine in the Department of Obstetrics, Gynecology, and Reproductive Sciences, in the Department of Microbiology and Molecular Genetics, and the Director of Reproductive Infectious Disease Research at McGee Women's Hospital of the University of Pittsburgh Medical Center. She received her PhD from Washington State University in bacteriology and public health and completed postdoctoral training in laboratory medicine at the University of Washington. And she's here to speak to us about biomarkers for diagnosing PID. Where are we? Welcome, Sharon, and thank you for being here.
Thanks so much, and it's a real pleasure to be here with you this afternoon. And really great thanks to both Kristen and to Susan for really laying the groundwork for what I have to say today. So you've already seen my disclosure, so I'm going to jump right into the natural disaster that is pelvic inflammatory disease. You've heard already that about 2 million cases occur in U.S. women, that Black women are disproportionately represented, and that in fact in 2015 to 2017, we're seeing an increasing number of cases of PID in Black women. So I would argue that both PID and its sequelae, infertility, pelvic pain, and ectopic pregnancy, are an increasing public health issue and of particular concern for Black women. So why do we need a biomarker for PID? I think after the last talk, you don't need me to tell you why, honestly. I would say that for PID, we need two kinds of biomarkers. Predictive biomarkers to help us understand if a woman is more likely to develop PID. And we also need diagnostic biomarkers, which would help us understand whether a woman has more significant PID, which could benefit from more intensive or longer treatment. I think that Kristen's talk a few minutes ago and combined with Sue's talk in this session really have shown us why we can't just use gonorrhea and chlamydia as biomarkers of PID. Because in fact, most women with clinically diagnosed PID do not have either gonorrhea or chlamydia. So what should we do? Well, I'm going to speak just for a moment or two about a wonderful study that was conducted by my colleague, Harold Weisenfeld, here in Pittsburgh, called the ACE trial. And it was a randomized trial of treatment with and without metronidazole. And it included about 233 women who came in with acute PID. And in that study, we were able to obtain endometrial biopsy samples in order to evaluate whether they had endometritis and to look at the etiology of their PID. And in short, what we saw was that about a quarter of women who came in with symptoms of PID and met all the CDC definitions actually had nothing in the endometrial cavity, no pathogens at all, and probably had pelvic pain due to other reasons. We also learned that gonorrhea and chlamydia are not only not the predominant cause, but are infrequently the only things there, with gonorrhea and chlamydia alone accounting for only about 1 in 7 infections, and that about 56% of women, over half, had essentially what we would call non-STD pathogens. So what are those? And I apologize for the busyness of this slide, but the point is, as you've seen multiple times today, we understand that chlamydia and gonorrhea, and maybe M. genitalium, are associated with endometritis. As you see here in this ACE study, we had 52 women with histologically confirmed endometritis and 97 who didn't have it. And clearly, chlamydia and gonorrhea were much more likely to be present in those with endometritis. But as you'll see at the bottom of that slide, there are also an important association between Gardnerella vaginalis, Atopobium vaginae, some other pathogens like E. coli and H. flu, as well as some more fastidious organisms like Megasphaera, anaerobic gram-negative rods like Dialyster or Prevotella, and anaerobic gram-positive cocci like Feingoldea or Anaerococcus, which most of you probably don't think about so much. The bottom line is that a smaller proportion of women actually have gonorrhea and chlamydia, and many have a heterogeneous range of microorganisms present. So with that complexity, is it possible to identify a biomarker for acquisition of PID? We get some hints from an old study published by Roberta Ness and her colleagues about 15 years ago. In this study, 1,100 women were enrolled at 5 centers and followed for 3 years to look for incident PID. And in the study, this was before we did quantitative PCR in the vagina, using cultivation-based methods, what we found were that BV-associated microbiota at the highest concentrations were associated with a twofold increased risk of symptomatic PID. I bring that up because just this year, we had published in May of 2020 a follow-up to that study by Catherine Haggerty, along with her colleagues from University of Washington and the Fred Hutchinson Cancer Research Center. And in this study, they did a nested case control of 17 women who had PID with endometritis and 17 controls from that last study I showed you. And as shown here, you can see that using quantitative 16S ribosomal RNA PCR, that Atopobium vaginae, Snethia, Megasphaera, Egerthella, and Prevotella amnii were each statistically associated with a 4 or greater fold increased risk of endometritis. And further, what you can see is that several other of these BV organisms were associated with an enhanced risk, but not M. genitalium and not the ureaplasmas. So what does that mean? It really means that we have some hints that certain BV-associated bacteria found in high concentrations may in fact be good biomarkers for acquisition of PID, along with gonorrhea, chlamydia, and perhaps in the M. genitalium. And you heard in the last talk that we really haven't had adequately sized studies to really put a nail in this about what would we need to do to holistically improve women's outcome. During the recent CDC STD workshop that we had focused on pelvic inflammatory disease, our group really thought that we would maybe need something like 10,000 women followed longitudinally for 3 years to generate these 150 cases of histologically confirmed PID that would allow us to really understand the relative amount of impact that gonorrhea, chlamydia, and these BV pathogens have on incident PID. So now let's talk about diagnostic biomarkers for PID. Well, why we need it is clear. If we want to really diagnose PID, we need to do an endometrial biopsy, but that's both invasive and not routinely performed when women with PID symptoms present for care. But there are 2 possible biomarkers for PID that have emerged in the past couple of years. The first are the use of blood tests for biomarkers of upper tract infection using microarrays. And the second is the idea of using a vaginal swab as a diagnostic tool to identify the microbial risk factors for those with endometritis. And I'd like to touch on each of those in the next minute or two. Just in 2018, Sang and colleagues from the University of North Carolina, part of Tony Darville's group, used some of the data from this ACE study that I just talked about to compare blood messenger RNA responses in women with gonorrhea, chlamydia-induced PID, in women who had gonorrhea and chlamydia but didn't have PID, and asymptomatic uninfected women. And from this, they identified 4,952 transcripts and looked at these by microarray. And what you can see, and if you read this paper, is that women with GCCT-induced PID had overexpression of a number of factors, including myeloid cell genes and suppression of protein synthesis, mitochondrial oxidative phosphorylation, and T cell specific genes. And so they concluded from this study, which was very hypothesis generating, that blood microarrays may be able to identify discrete endotypes among women who come in with symptoms of PID to really understand whether or not invasive infection had occurred. So very interesting, very early. A second strategy is one that we employed, again using the ACE study. And we reported this last year at the STI HIV World Congress in Vancouver, British Columbia. And it seems so reminiscent to think about the beauty of being in person. In this study, as I mentioned, we did endometrial biopsies and identified those as having acute endometritis as those who had plasma cells and neutrophils in their endometrium. And then we actually did PCR, quantitative PCR tests for a range of microorganisms in the vagina. So what we found in that study was, first of all, that there were a range of organisms associated with endometritis. In this subset analysis, we looked at 31 women with histologic endometritis and symptoms of PID and 138 women without endometritis. And what you can see is that higher concentrations of Gardnerella vaginalis, Adipobium vaginae, Megasphaera, Prevotella timonensis, Amnii, and Prevotella bibia were each associated with a statistically significant higher prevalence of acute endometritis when these organisms were present in the endometrium. We also found that women who had L. crispatus or Lactobacillus jensenii in the vagina were significantly less likely to have acute endometritis. And so Leslie Mine, who's one of our collaborators here at the University of Pittsburgh, developed an endometritis score using factor analysis and logistic regression models to essentially look at all of the organisms we looked at and then did ROC curves to choose the best performing score. So this is what we have developed as an endometritis score. So essentially, you would take a vaginal swab, you would do a limited set of quantitative PCRs for C. trachomatis, G. vaginalis, Adipobium, Prevotella amnii, and L. crispatus. And if you had a score of greater than 4, it would indicate a higher risk of endometritis. So you could get that, for example, if you had chlamydia in the cervix, plus you had high levels of Gardnerella, Adipobium vaginae, or Prevotella, and you didn't have Lactobacillus crispatus. Or you could get it without chlamydia if you had high levels of 3 of these organisms, absent Lactobacillus. So what does it look like when we do the ROC curves for this? We find that this type of model would give us 87% sensitivity and 74% specificity in identifying the subset of women with endometritis. So very quickly, we have identified 2 types of biomarkers for PID. Predictive biomarkers, we have old studies showing that high concentrations of some BV-associated bacteria in the vagina and absence of lactobacilli are associated with a 2-fold risk of acquisition of PID. And then that small nested case control study just published this year showing that several BV-associated bacteria have been linked with higher risk of PID, though limited by small sample size. Under diagnostic biomarkers of PID, we have now these blood microarrays that look quite interesting in identifying invasive gonorrhea and chlamydial infection. And the data I just showed you that certain BV-associated bacteria along with lactobacillus can be used to develop a score that can predict endometritis. So to summarize, the etiology of PID in the US is predominantly not gonorrhea or chlamydia. Screening and treatment programs for gonorrhea and chlamydia are necessary but insufficient, and that we essentially may be able to develop both predictive and diagnostic biomarkers of PID But I would argue we need to do a lot more investment in actually studying prospectively women at risk of PID so that we can understand the attributable fraction due to the STI pathogens versus the non-STI pathogens. Thanks so much.
Thank you, Sharon. Wonderful. So we've made it through the 3 presentations and have 5 minutes for questions. And I'm happy to say a few have come in our Q&A chat function. So I will read them to our speakers, and hopefully we will manage this with y'all turning your cameras back on and your microphones. So let's go to the one from Charlotte Gatiss first. Thank you, Charlotte, for asking a question. It was for Kristen, and I will read it here. Which data set do you value the most, and which has the most accurate data in your opinion?
So I wasn't sure if I was supposed to answer these in the box on the right, so I actually already answered this, but I'll read my answer. So I think that it's a really difficult question to answer. And I think the reason being that each data source really kind of answers a different question. And so I think you have to know what your question is in order to know which data source to use. So I think if you want more information about prevalence, you're going to go to NHANES or NSFG. But unfortunately, the problem with those data sets is that they have small sample sizes and often are based, both of them are based on self-report. HCUP is going to be incident cases, but it is visit-based, not person-based, so you can't follow a patient over time. So I think what I learned from these analyses is that it's not really one data source that can be used to answer all PID questions, and it's not one that's really better than the other. They each are kind of separate and answer their own specific questions.
Thank you, Kristen. Great. I'm not sure that our audience can see our typed in responses. So we'll go through the questions. I think this one maybe for Dr. It's from Marina Leonardos. Thank you for asking this question. Susan, have there been any studies that look at a link between PID and the risk of HIV acquisition?
Is that to me or to Susan?
Susan, can you hear me? I think it is for Susan. But she may not be able to hear.
Yeah, I think your mic keeps cutting in and out. Susan, Marina Leonardos asked if
I can't hear anybody.
I think you better take it, Kristen.
Okay. Okay, so
I can hear Sharon, but I can't hear Kristen.
Okay,
or Ellen.
I'm going to try to take this. I'm not aware of any studies that show an association between PID and risk of HIV acquisition. I think that if you think logically about it, if the PID was caused by chlamydia, I know chlamydia can increase a person's risk of acquiring HIV. So if it was the PID was caused by chlamydia, maybe that would increase it, but I'm not aware.
I think we're getting technical difficulties, so I apologize for that. But given that we're at the end of the hour, I want to thank everyone for their participation, and we will copy those questions out and send them to our speakers via email, and hopefully they can answer them through that. And with that, I'd like to end the webinar, and I thank you everyone for your participation. Bye.